Hello, this is Harry Campbell from Biofeedback Resources International, and I'm joined by Dr. Jorge Palacios. We're continuing our webinar series on neurofeedback and QEEG with various topics. Today, we're going to be talking about depression and also PTSD and how neurofeedback connects with that. So I'll just start my section here. Okay. All right. So this is our topic, depression and PTSD, neurofeedback contributions and interventions. And I have just a short piece here that we're going to go through and then hand the rest of the discussion off to Dr. Palacios. So this is talking about depression and depression, or in this case, we have listed here definitions of major depressive disorder, also known as clinical depression, is a mental disorder characterized by at least 2 weeks of pervasive low mood, low self-esteem, and loss of interest or pleasure in normally enjoyable activities. Introduced by a group of US clinicians in the mid-1970s, the term was adopted by the American Psychiatric Association for the symptom cluster under mood disorders in the 1980 version of the Diagnostic and Statistical Manual of Mental Disorders, DSM-3, at that time, and has become widely used since. And depression is a big problem, both in the United States and in other places in the world. It seems to, in many cases, have been getting worse over the last several years. I know COVID has also played a role in increasing some of the symptoms there, and there's also a big connection in suicides, which is also a big problem. Some of the symptoms and signs of depression: it significantly affects a person's family and personal relationships, work or school life, sleeping and eating habits, general health as well. A person having major depressive episode usually exhibits a low mood, which pervades all aspects of life, and an inability to experience pleasure in previously enjoyable activities. Depressed people may be preoccupied with or ruminate over thoughts and feelings of worthlessness, inappropriate guilt or regret, helplessness or hopelessness. And often I notice that it's hard for a person who's not depressed to understand what the person is experiencing, and it seems difficult for them to relate it to other people. And so sometimes if a person doesn't understand what the other person is going through, is very difficult for them to put themselves in that place, and they don't understand why they don't just snap out of it. So it can be a very difficult situation for a person who is depressed. Then we have PTSD, and you can see many different things that are associated with PTSD. It's a post-traumatic stress disorder. It's very common in veterans, and a lot of the clients that I work with are in the veterans hospitals, and they work with veterans, and many of them are suffering from PTSD, and some of the symptoms that go along with that, including just being on alert, constant alert all the time, and feeling like they are needing to deal with emergency situations that don't necessarily exist at that time. And just going back here, I just wanted to mention some of the things here, like it talks about sleep. And sleep can be a big problem in many different disorders, including depression, including PTSD. And when we work with neurofeedback, it tends to be one of the things that might start to change the earliest. So you may have a list of symptoms that a person has, and if they're not sleeping well, it seems to be one of the things that may start to improve earlier. So I just wanted to mention that because I remembered sleep was on that other slide that we just looked at. So now if we look at PTSD, it's a mental and behavioral disorder that can develop because of exposure to a traumatic event, such as sexual assault, warfare, traffic collisions. And I think that's one of the things that sometimes people don't think about when they think about PTSD. Traffic accidents are very common, and it's not thought of in the same way as, say, a person who's been involved in warfare. But I worked with people that were in car accidents over about a period of about 8 years, and the problems that they develop around trauma from that can be very severe. In fact, many will not drive anymore, or they have a lot of difficulty getting back to driving because because of the trauma connected to it. So traffic collisions is another area that I think should be looked at in terms of PTSD. Then you have child abuse, domestic violence, other threats on a person's life. Symptoms may include disturbing thoughts, feelings, or dreams related to the events, mental or physical distress to trauma-related cues, attempts to avoid trauma-related cues, like I talked about with the driving, alterations in the way a person thinks and feels, and an increase in fight or flight response. These symptoms last for more than a month after the event. The person with PTSD is at higher risk of suicide and intentional self-harm. So with the connection with neurofeedback comes the term neuroplasticity, and the brain changes. And so this is where we will be discussing, Dr. Palacios will be discussing more about how neurofeedback is related to and used with these types of symptoms, because the brain, we can say, is dysregulated in some way when a person has these types of symptoms in most cases, and being able to assess the ways that the brain is dysregulated using the QEEG or neurofeedback equipment, and then using the neurofeedback to help to regulate the brain activity is what we will be discussing. And all of this we're going to be giving you a sort of an introductory level of what we do in today's session, but we're building up to the full training that we're going to be doing in September, and we'll give you the exact dates on one of the slides here, that we're going to be doing in Florida, and that's going to be in St. Petersburg, Florida, where we'll go in depth in teaching about neurofeedback, and not just these applications, but other applications that we talked about in some of the other webinar sessions, in addition to these two. So that's my information that I wanted to share. I'm going to pass this over to Dr. Palacios. He's going to continue with some more detail, and this is the information on the training that we're going to be doing in neurofeedback, September 14th through the 17th in St. Petersburg, Florida. You can call our office to get more information. The phone numbers are listed there, and also the information is listed on our website, where there's information to register and more details about the training and what's included. So thank you for listening, and I'm going to pass this over to Dr. Palacios.
Hello, everybody. Thank you very much, Harry. Let's beginning by sharing my screen. And in just a moment, the presentation. Yes, indeed, the neurofeedback seminar is going to be in St. Petersburg, Florida, also known by locals as Stampede, and it's going to be held from September 14 to 17 this year. And these webinar series are being made just to give some information to all the people interested in this seminar of the topics and the kind of information that is going to be presented for training. Of course, the training is going to be more specific in different type of topics. Today, we are going to talk precisely about depression and PTSD, post-traumatic stress disorder. I want to talk with you about neurophysiological markers and the treatment protocols in general, and the role these neurophysiological markers play in the diagnosis, in the assessment, and the treatment protocols in general. Just for information, all the recordings and images and neuroimages were processed by me in the neuroinformatic environment called Brainstorm. There it is the reference for all those who want to know more about this type of work in neurophysiology, which is in the field of neuroinformatics. Prevalence just in US is very important. Just think prevalence of depression. Just think that not in very recent studies of the prevalence, just for example, this one of 2019, it was estimated that 19.4 million adults from 18 or older in the whole United States have had at least one major depressive episode. We are not talking only about feeling a little bit down. We are talking about what Harvey just mentioned, major depressive episode, which means an important change of the not only personality, but the whole dynamic of the whole life dynamics, and also the family dynamics. It could be the origin or the origins family, or could be the nuclear family that is being affected by the depression. Is most common in women, and but also it can be found in men, and it can be said that from the people that suffers from depression, it can be centered in the ages of between 26 to 49, precisely when the responsibilities of life are beginning in the 26 years of age, are beginning to get more complicated. And then during all the spectrum where the expectations or achievement are to be more intense, are precisely those periods of time where depression as a major illness or as an episodic illness have a different kind of onsets. In the speaking about neurophysiological markers, and you can see this neuro image that I'm going to describe in more detail. There are certain specific changes that were beginning to be described since the early 1980s. Right now, with the major advances in neuroinformatics, it can be done with more specific detail and with much more precision, the identification of these markers. here we are looking at an image that a simple view can represent just the brain and the head and certain points, certain head points, which are representing the electrons. For more details, this image was obtained in the same neuroinformatic environment I was talking about before, but following a specific pipeline of processing the recordings. There is the reference of this type of pipeline by Niso et al. What does this pipeline represents? Well, it represents many things, but mainly depression. What we are looking here is a brain that has been recorded in the resting state. That means the brain doing nothing. It is not involved in any kind of task. This kind of state has been described in opposition to the working state, which is performing any kind of task. In this case, we can describe, as many people know by now, two different conditions of the resting state. One is with the eyes opened and the other one with the eyes closed. This image was obtained with the eyes closed from a 49-year-old female gender individual. And we can observe here an important concentration of a specific EEG brainwave. This kind of image is representing the amount of power of the different brainwaves, but it is also identifying the sources. That means the place where the activity has been generated. And here we can see what it is called the asymmetry. This image is only for one specific brainwave, the alpha frequency between 8 and 13 hertz. And as you can see in this individual, there is not the usual distribution of the alpha frequency in the temporal parietal occipital areas, and a huge concentration of the power of the sources in the frontal left frontal lobe, in specific areas of the frontal lobe. This is a neurophysiological marker. This type of marker was initially described by different authors, but by a specific group in the early 1980s, and since then there has been a lot of contribution for the study, the neurophysiological description of the different characteristics of depression in the organization of the brainwaves. So we can see in the slide a very different type of brain. It is not just an image, it is an image of the brain. It is a smooth surface of the brain. So we can, what we have done here, we have smooth the brainwave circumvolutions in order to have a more spread view of the localization of the sources and the localization of the concentration of the power of the alpha frequency. And this is more or less the same kind of analysis, but in a different condition, with the eyes open, of the same person in a different type of times, at the 448 seconds and the 492. And you can see in these two slides how the concentration of this type of asymmetry is still on here in this zone and here in this zone. Initially, the neurophysiological markers of depression were identified in the dorsolateral prefrontal cortex, which is this area. But with different kind of studies, it has been found that it is in specific areas of the brain, and it was necessary to use different type of atlases of the brain, more recent studies that came from the connectome era. We can now talk about the parcellation of the brain before the connectome and after the connectome. So we are going to look here at parcellation after the connectome. It's a fact that in the dorsal prefrontal cortex, dorsolateral prefrontal cortex, it is the zone where it is the residence, as we can say, of many processes, but in specific of the neurophysiological markers of what we are saying here in this slide, the alpha asymmetry. And what is this? What do this mean? Well, first of all, we have to consider that the alpha presence has always been linked to hypoactivity of the brain. That means when there is more alpha frequency activity, there is more hypoactivity in the brain, which is related to the first initial states described related to the alpha tracings, like relaxation feelings, meditation, mindfulness, and all those states related with the quiet or the of mind, or with the peaceful of mind. Well, but it is also a marker of hypoactivity. And when the brain is in the resting state with a different kind of distribution of the sources of power, then we have a marker with a very different type of condition. In fact, since the works of Hammond, that was the first of describe this kind of marker, the asymmetry of alpha frequency. He described not only the asymmetry, but also that it can be identified, this marker, as a specific marker, for example, for state or trait of anxiety, of depression. In fact, not only for depression, but also for anxiety. And not only for state or trait, in the case of personality, but also it can be found in the newborn child of depressive people. Now, today, thank you to AI, we can have a technology that is developing EEG analysis as a biometric tool. In a few years, we are going to see how EEG is being used as a biometric tool. And for now, we can say that the depression was, and all this kind of research in neurophysiological markers are the basic contributions of this type of work. Well, here we have one type of not only neurophysiological marker, but also a biometric identity element that is going to be taking on in this type of work. So here we're looking in this moment more intensity, the neurophysiological marker, and then the intensity is lower in this moment. We are talking about two different moments in the recording, but it is still present. Now, what are the treatment protocols? Well, the treatment protocols for neurofeedback are based precisely in these elements that we have been talking about. Davidson in 1992 and the group of Elsa Bayer, they developed the first protocols that were the milestone in the neurofeedback treatment of depression. It is a mixed protocol, a combined protocol with different elements that today doesn't have to surprise us very much. First of all, it is a protocol that can be successfully combined with the pharmacological treatment. That's the reason why many psychiatrists are being trained since then in the use of this type of neurofeedback protocol, so they can be able to treat their patients also with neurofeedback and not only with drugs. At the same time, it is an important measure of the effect of the drugs, and these researchers found that since those days that when the treatment is obtaining results, and when we are obtaining more results with the treatment, there is no need of the same doses of medication, and it can be reduced. Here, using a different atlas, because you have to remember that the dorsolateral prefrontal cortex belongs to the classical and the milestone contribution of Brodmann. This type of parcellation is from a very new atlas from Destro. You can see the Destro et al. You can see the reference in your screen, and then you can see two specific parcellation, which is the model and the middle frontal gyrus in the left frontal lobe with the frontal midnight triangle part, also of the inferior frontal gyrus here, and both parcels of the brain are the most important areas of the brain where the neurophysiological markers of depression can be found. You can see here also that these elements are pretty clear in this image, this neuro image, that it is the same image that you just saw before, but in this case, the difference is that the parcellation are superimposed in the neuro image. So we can identify with more precision the areas of the brain that has been involved in this case and in many others in depression. Of course, I have not to say that this parcellation comes with coordinates and many other elements, numerical elements for delimitation. It was the work of Henriquez and Davidson in 1994 that came with the proposal for a simple but useful formula to estimate the asymmetry values. As you can see in the screen, there is the logarithmic base formula where the logarithmic values of R minus the logarithmic values of L, where R is F4 and L is F3, are the basic elements of the calculation in those days for the calculation of the values of one element, which was called asymmetry. And why is so important asymmetry? Well, it is important because in the healthy brain there is no asymmetry. or asymmetry is very small. The values of asymmetry are the difference of asymmetry are just statistically not significant. The brain has two main important measures of healthiness. One is synchrony. That means that the same frequencies are at the same time in the same places, of course, in the same range, in the same moment, and with the same values of voltage, the same power, the same amount of power or energy of the different frequency bands, and of course, at the same time. So at the same time, which is synchrony, and at the same time of the values of the power, it is the asymmetry. That means that you can find at the same moment in the equidistant places in the same brain, the same frequencies with the same amount of power, the same amount of microvolts. When there is asymmetry, for example, in the alpha activity in the posterior areas, occipital or parietal or temporal parietal occipital, well, there is an important neurophysiological marker, and also we have found asymmetry in beta activity, which can also presume there are important things happening, not always condition, not always illness, but asymmetry is a measure of healthiness in the brain, and also asynchrony. So remember, brain has to be synchronic and symmetrical values all the time. And here we can see in this image that was generated in the same neuroinformatic environment, the next generation that was proposed of calculation of asymmetry that was proposed for the group of Bayer et al. Just for the same years. And that is simply stated in these elements. Asymmetry can be measured in a simple statement. When alpha in the F4 position, which is this one in the hemisphere, the right hemisphere in the right frontal lobe, is bigger than the alpha activity in F3, which is the equivalent site in the frontal, in the left frontal lobe, then we can identify, and it has been identified with anxiety states. And the opposite, when the asymmetry comes from the left frontal lobe, it corresponds to a depression state. In the cases of bipolar depression, then it all depends for the moment when the person is measured. If it is during a maniac episode, then we are going to see the asymmetry in the right frontal lobe. And if it is during the depression, depressive state, well, it is going to be the asymmetry in the left frontal lobe. All these findings, remember, that are based in the assumption that the alpha frequency is a measure of hypoactivity. That means also that there is hypoactivity, normal, natural hypoactivity, and there is also abnormal, pathological hypoactivity. This was the initial product. It was F3 referred to FCT, F4 referred to FCT with only one measure that was calculated online according to the formula, to the calculation that we just see before, and that was organized to be presented in a form of different types of graphics, on-screen graphics, as a way of delivering the feedback to the patient. The patient was trained to reduce the amount of symmetry to 0. Just think that this was made in the 1994 with the systems, with the computers of those days. Today, it can be done much more different and complicated protocols by fortune. Now, speaking about that, here we are looking at another image generated in the same environment, and we are looking at the left hemisphere, the frontal lobe hemisphere, and this is an image of the head here in gray with the MRI superimposed in a 3D presentation, and also in a ghost presentation, the cortex in volume. So we can identify the electrodes that are in orange, F1. This is not the traditional 1020 international system, but the 10-10 system, which is referred to the 10% of the distances between the electrodes, and it comes with the result of 64 or more electrodes. And we have different sites. We have here different sites, like, for example, AF seat, which is the anterior frontal sagittal electrode, F1, F3, and F5. So in these areas are located the sites where the biofeedback can be performed. The new protocols, we're going to talk about this also a little bit in our seminar. The new protocols in the new field, the emergent field of HD for high density QEEG biofeedback, also in the field of the functional MRI and the MEG biofeedback, or magnetoelectroencephalography biofeedback protocols. They have been developing, consider not only this type of sites, but more complicated sites that are related to more specific positions, precisely related to these areas. Here we see the same image, but with the parcellation of the straw atlas and the sites indicated in the case of high density 32 channels, which is of the high density recordings. It is the low density recording type, and here you see how this type of hookup precisely is related to these areas we discussed before from the straw atlas, and that are the areas related to depression. So we have come to a point where there are going to be included more sites in the different protocols. We are going to be using high density QEEG systems, and considering in the online and the offline elements for coordinated systems and all the recent advances that you can see of the brain parcellations. Not to mention also the connectivity and the different elements in brain connectivity. So this is another point of view of these emerging fields that are going to be milestones also in the study of the neurofeedback of different type of mental health issues like depression. And of course, nothing of this could be possible, not only for these great contributions in the different fields of the neuroinformatics and electrophysiology, but also of the natural basis of the natural properties of the brain, with like neuroplasticity that Harry just mentioned before. When we talk about neurofeedback, we are talking about a specific type of neuroplasticity, which is electrical or electrophysiological neuroplasticity. That means the property of the reorganization of the neurophysiological activity of the brain due to experience, precisely due to experience. So many of these things and the details of this type of protocols and the classical protocols for classical neurofeedback will be discussed soon, discussed soon and teach soon in September in St. Pete's. And also just a few slides to talk about post-traumatic stress disorder. Now we are going to use the same type of images, the same type of brain images, but with the traditional protocols for PTSD disorder. And here we are talking, let me tell you that when we are talking about neurofeedback protocols and about neurofeedback markers, the physiological markers, we are talking about a great amount of milestones and trailblazers of neurofeedback history. Here we have the traditional hookup that we just see before for depression, but this was made before it was used. In the case of depression, it was used for the treatment of post-traumatic stress disorder. There are different types of protocols because Peniston and Glukowski develop different type of protocols. This is centered in the frontal lobes because it is related to depression. You know that one of the most important symptoms in the PTSD is depression. There are also other types of protocols that are mainly in the parietal, temporoparietal, and temporo-occipital and parietal zones, not for the asymmetry of alpha frequency, but for the increase of the synchrony and symmetry of the alpha frequency in those areas. As you can see, now after all the things that we just briefly talked, there is an important neurophysiological marker in these two cases that is in common. What post-traumatic stress disorder and depression have in common is the disorganization of the alpha frequency in the whole brain, in the resting state and condition, and also in the working state condition. And if in the resting state condition the alpha frequency is disorganized, just imagine what it happens when the rest of the brain frequencies also disorganized are trying to get together and put together into a working task. Of course, this is going to be a very difficult situation for those brains that are suffering from this type of disorganization found in PTSD and also in depression. And from these classical protocols from Peniston and Gulkowski, it was developed a huge amount of protocols also for the treatment of substance abuse, for alcoholism and alcohol abuse, and PTSD, of course, and certain type of anxiety disorders. As you can see, it seems that when it comes to the alpha frequency in the treatment of this type of mental health conditions, we have to pay attention to the whole brain, not only to certain specific brain. It comes to a difficult situation when we are working only with classical neurofeedback devices, but when we work with 4 channels or more, we can manage this type of work. This is going to be teach at the seminar in September. Just to finish here, we are looking at different type of protocols that are also being used to cope, to teach the patients to cope with depression in the case of PTSD, which is a great health issue, as you can saw before in the statistic that I just presented. Well, this is just a few elements that we are going to talk about in the neurofeedback seminar the next September. I hope all the visitors to this webinar will be interested in to join us next September. For me, this is all. Thank you very much for your attention. Thank you, Harry.
You're welcome. Thank you. So you can, of course, anyone who is interested in finding out more, please contact us. I gave information earlier in the slides. The website, biofeedbackinternational.com, or the phone numbers, if you're in the U.S., toll-free 877-669-6463 or 914-762-4646 for more information on the training that we're going to be doing in September, and also to register, you can contact us there. So thanks again for attending, and we hope to see you in the next session.